I keep going to the river to pray, 'cause I need something that can wash out the pain. And at most, I'm sleeping all these demons away, but your ghost, the ghost of you, it keeps me awake.
This is the second video tutorial for the FRCR Part 2 exams, where we try to cover pretty much everything you need to know for the 2A and the 2B. The videos are designed for when you're too tired to revise and just want to relax and absorb information, essentially replacing your evening Netflix time. So if you haven't already, hit pause, get comfortable, make yourself a drink or a snack. There is no pen and paper required. Whenever you're ready, hit play and we'll get going. We're going to cover solid and cystic mass lesions, the important associated syndromes, and end with a short quiz to test everything that you've learnt. Just like last time, there are some very lovely people, much cleverer than myself, who I do need to thank. This time, Dr. Miller has very kindly been through my slides, and Dr. Zaka has pointed me in the direction of some important studies. I'm sure we are all very grateful to them. All knowledge begins with anatomy, and as radiologists, anatomy really ought to be your forte. So a quick basic recap of the kidney. We start with a tough outer fibrous capsule. Deep to the capsule is the cortex, which then extends deeper into the medulla. The medulla is divided into triangular shapes called pyramids. The apex of each pyramid is called a papilla, and each papilla is surrounded by a minor calyx, which collects up all the urine. A few minor calyces come together into a major calyx, and urine goes from the major calyces into the funnel-shaped renal pelvis, which drains into the ureter, obviously then draining into the bladder. Throwback to med school now, the basic building block of the kidney, our old friend the nephron. Each kidney has around 2 million nephrons. It has a Bowman's capsule where glomerular filtration takes place, a proximal and distal convoluted tubule separated by the loop of Henle, which dips down into the medulla. Around 6 nephrons drain into a collecting duct. The collecting duct fuse together deep into the medulla into around 20 large ducts at each papilla. Now, if you haven't done much in the way of GU, then here is what usually happens. Patients present with persistent hematuria, an extremely common complaint. What we need to do is rule out cancer from both the upper and the lower urinary tract. To exclude lower urinary tract malignancy, the patients usually have a flexicystoscopy by a urologist. That's often done before the CT. Then they have the imaging, which involves a plain KUB type scan to rule out stones, and then imaging of the kidneys and ureters. In most cases, it's a split bolus technique, which gives you a mixed nephrogenic and excretory image around 90 seconds. There is going to be a fair amount of talk on enhancement, so it figures we really ought to define it from the outset. Most centres will use a cutoff of around 20 Hounsfield units to define enhancement on CT and 20% increase in signal intensity to define enhancement on MRI. Most of this talk is on solid lesions, and there are 5 big ones we need to cover. We're going to start with the most important, renal cell carcinoma, and it's the one we're going to spend the most time on. This is an obligatory slide on RCC risk factors. Most medical students can recite this list off by heart, so I'm not going to read them out to you. What I am going to do is mention paraneoplastic syndromes. These occur in around 25% of patients with RCC, and there are a few different ways these can worm themselves into your exam questions, so it pays to know them. Hypertension and hypercalcemia are self-explanatory. Polycythemia occurs due to excess EPO secretion, and there's something called Storfer syndrome that I've seen mentioned a couple of times in practice questions. This is essentially hepatomegaly without any hepatic metastases. It can occur with other malignancies, but renal cell carcinoma is by far the most common. So if you do have that question with a bunch of options, you're going to pick renal cell carcinoma. So Storfer syndrome is hepatomegaly without any hepatic metastases in the presence of usually renal cell carcinoma. I say this at every teaching I do. If you understand the pathology and the pathophysiology of a lesion, then you don't have to rote learn things. So, with that in mind, here is our old friend the nephron and the three most common RCC subtypes that you should be aware of. RCCs arise from the epithelium of the tubules. The majority are clear cell renal cell carcinomas arising from the proximal convoluted tubule. The next most common are papillary renal cell carcinomas arising from the distal convoluted tubule. And finally, the rarest chromophobe arise from the collecting ducts. Let's begin with the most common subtype, clear cell RCC. Clear cell is either sporadic, which is more common, or associated with a syndrome. In the sporadic form of clear cell, it's characterized by a loss of the short arm of chromosome 3. That's chromosome 3 there. And what sits on the short arm of chromosome 3? The von Hippel Lindau tumor suppressor gene. In 84% of clear cell RCCs, the VHL tumor suppressor gene has been inactivated. Now, what does the VHL gene do? It codes for a protein, and this protein in the presence of oxygen will degrade something called hypoxia-induced factor alpha. What is HIF alpha and why does it need degrading? HIF alpha causes transcription of lots of pro-angiogenic factors. The two key ones are vascular endothelial growth factor and platelet-derived growth factor. All of these factors promote angiogenesis, cell proliferation, and cell survival. So if you inactivate VHL, you don't degrade HIF alpha, and you overproduce all of these pro-angiogenic factors. The result then is lots of cells with clear looking cytoplasm. The cytoplasm looks clear because of the high lipid content, hence the name clear cell RCC. You also get necrotic and cystic degeneration and of course lots of angiogenesis. Now these cells are arranged in clusters within the tumour. It's called a nested or an alveolar architecture, presumably because it looks like alveoli. You can see it on this histology specimen here, these clusters of cells. The genetics is all very well, but why have I gone through it? I've gone through it for a reason, because without having to memorize anything, you now already know what the imaging features of clear cell RCC will be. We know because of all the pro-angiogenic factors, it's a very, very vascular lesion, so you will get avid enhancement on imaging. This nested alveolar architecture is what gives it a high T2 signal on MR. We also know, because of all these pro-angiogenic factors, the hemorrhage, necrosis and cystic degeneration are going to give it a heterogeneous signal on T2 imaging. And we also know that the clear cell, the cytoplasm, because it's full of lipids, is going to give a signal drop on the chemical shift imaging. So without having memorized anything, we already know what the imaging features are of clear cell RCC. This is a very typical RCC, a heterogeneous, avidly enhancing mass. The development of papillary RCC, remember this is the one that arises from the distal convoluted tubule. The development here is different. The problem with papillary RCC occurs on chromosome 7, where there is mutation of the MET gene. This occurs in both sporadic and the hereditary forms of papillary RCC. MET encodes a tyrosine kinase receptor that binds something called hepatocyte growth factor 1. This pathway is what's responsible for cell proliferation, motility, and survival. That doesn't matter. Crucially, what I want you to remember is that papillary RCC does not have the von Hippel Lindau HIF-alpha vascular endothelial growth factor pathway. That pathway is a key characteristic feature of clear cell RCC, but is not a feature of papillary RCC. As a result, you don't get a load of angiogenesis, and this lesion is hypovascular. What you do get is this papillary histology. It looks very different to the nested alveolar architecture we saw with clear cell. This papillary histology describes nipple-like projections that you can see on this slide with a fibrovascular core. Remember, clear cell, the alveolar nested architecture, gave it a high T2 signal on MRI. A papillary histology, this gives papillary RCC a low signal on T2 weighted MR imaging. So to summarize papillary RCC, it's the most common dialysis associated RCC. It's not driven by the VEGF pathway, so it's a hypovascular lesion which is poorly enhancing. We've already said the papillary architecture gives it a low T2 signal on MRI, and it contains hemosiderin, which means you will get signal loss on the in-phase imaging. So a lot of these things are the opposite to clear cell RCC. This here is a nice example of a papillary RCC from a recent MDT at my current trust, and you can see nicely how the kidney is enhancing whereas the lesion is not. There are two more I have to mention. Chromophobe RCC is rare but generally has a better prognosis than the previous two. Tends to be a bit bigger, around 7 centimeters, and can show a central stellate scar and spoke wheel enhancement. But the key here is there are no imaging features that are characteristic. So these are diagnosed on histology after the lesion has been resected. Finally, medullary RCC. It's rare but is a popular exam question because it's easy. These are horrible, horrible tumours exclusive to young men with sickle cell disease. Prognosis is dismal. Survival is 15 months from diagnosis, and they do not respond to chemo whatsoever. So this is a very easy exam question. I've seen it multiple times. A patient with sickle cell, young male with a new renal mass which looks malignant, is going to be a medullary RCC. Here is an example of a chromophobe RCC, again taken from a recent MDT. As I've said, it's a large, poorly enhancing lesion, but there is nothing really characteristic. So this diagnosis was made after the lesion was resected. This patient had a nephrectomy. That's the tumours done. We have to talk staging. Now, we all know that the RCR say you don't have to memorize TNM staging for any lesion. That's fine, but you do need to know the important things that are going to upgrade a lesion from a T2 to a T3, for example. RCC staging is incredibly easy, so you may as well spend 3 minutes learning it. I've drawn here a kidney and an adrenal and an aorta and IVC. We have to first go over the anatomical spaces and then we'll talk about staging. So this here is Gerota's fascia. This here is the fascia of Zuckerkandl, and they come together at the lateral conal fascia. This space is the perirenal space. This is the peritoneum, and the space here is the anterior pararenal space. This is transversalis fascia, and the space here is the posterior pararenal space. So now the staging. This is nice and easy. Anything within the kidney is a T1 or a T2. The cutoff is 7 centimeters. So generally anything above 7 is a T2 and below 7 is a T1, but they are both within the kidney. Once we're out of the kidney, into the perinephric tissues or into a major vessel, usually the renal vein, then we are T3. And finally, if a tumour grows into the ipsilateral adrenal gland or out of Gerota's fascia, then it's a T4. The N and M part is easy also. N1 is locoregional lymph nodes and M1 is distant metastases. It's that simple. The only small thing to remember here is that if the involvement of the ipsilateral adrenal gland is contiguous, then that counts as T4 disease. But if it's non-contiguous, so if you have a lesion within the kidney and then a second lesion within the ipsilateral adrenal gland, then that's M1, that's metastases rather than T4. That's the TNM, and the staging follows along nicely. T1 is stage 1, a T2 lesion is stage 2, T3 shockingly is stage 3, and T4 is stage 4. Management questions are becoming increasingly popular in the 2A and 2B exams, so it pays to know your basics. Now, nephron-sparing surgery is ideal, and it's the optimal way to preserve renal function. Wherever technically feasible, so small peripheral exophytic lesions, that's what's done. If the tumour isn't suitable for a partial nephrectomy, for example, if it's large or central, then a total nephrectomy is the only option. Surprisingly, there is also a role for nephrectomy in metastatic renal cell cancer. It's not done with curative intent, but there is rationale. The proper term is called cytoreductive nephrectomy, and the reason it's done is this. RCC is a very immunogenic tumour. It's very good at manipulating and suppressing the host's natural immune response. So the primary tumour is said to act as an immunogenic sink. In other words, it's diverting all the circulating macrophages and lymphocytes away from the distant metastases. It also creates a load of mediators that promote inflammation and inhibit T cells. There's a bunch of different interleukins that you don't have to learn. So if you remove this big load of immunosuppressive tumour, then the reduced tumour burden improves the host's immune surveillance, and it also improves response to any further treatments you give them. That's one big reason. There also have been reports of metastases spontaneously regressing when the original tumour is removed, but these are very, very rare. And finally, once you remove the source of metastases, another good reason to get rid of it is that you sort of reset the clock as far as accumulation of tumour burden is concerned. Surgery is not always an option, whether that's due to patient age or comorbidities or disease extent. And there are two increasingly used non-surgical options that you do need to know about: radiofrequency ablation and SABR. Let's begin with radiofrequency ablation, and we'll start with the basics. Heat kills cancer. We know this, we have known this for decades. So how do we heat up a renal tumour? Well, we place an electrode through the skin into a lesion and then pass an electrical current through the electrode. That current will generate heat. We know that electrical currents through electrical conductors will produce heat. We know this because of a very famous law. We all did physics at school, so if anyone can remember without cheating whose law states this, put a comment in the comment section and you'll win the title of the cleverest radiologist of the week. If you really want, I'll send you a certificate. So we've poked an electrode into a lesion. We've placed it parallel to the longitudinal axis of the tumour and ensured that the tip is touching the deepest margin for the first treatment. I've seen this in exam questions before where they ask about electrode placement. The electrode is placed at the deepest margin of the lesion for the initial treatment. We've also ensured the electrical current has been grounded with some pads on the patient's thighs. And then the electrode we know contains an internal thermocouple for temperature measurement. The idea is that you systematically treat different bits of the lesion until the whole thing has been treated. We pass a current, heat up the cells, resulting in controlled cell death and necrosis. The actual term is death via coagulative necrosis. Again, another exam question, which is by which mechanism do cells die during radiofrequency ablation? And the answer here is coagulative necrosis. Now, cancer cells are more susceptible to heat damage than regular cells. They'll start to die around 41 degrees. You do need to reach 60 degrees throughout the lesion to actually ensure the cancer cells are dead, but you don't want to go too high. Anything over 105 and you'll start charring tissue. Again, this is an exam question I have seen. So for RFA, make sure you know where the electrode is placed. Make sure you know what the numbers are for cell death and the temperature you need to reach within the lesion. The very cool sounding SABR is a highly focused radiotherapy technique. So what's happening here is you're only treating the lesion with minimal effect on local tissues. It takes much fewer treatments than regular radiotherapy, and it's been proven to be safe and effective in RCC. So which one is better, RFA or SABR? Depends who you ask, but I've drawn up a nice comparative table for you that we'll quickly talk through. So RFA, although widely used, does not have an RCT behind it. The evidence is all case series based. SABR, however, has solid evidence showing it's safe and effective. SABR can generally handle larger lesions than RFA. It's also non-invasive. Radiotherapy does not require sedation or anesthesia, and RFA, on the other hand, will need general anesthetic in most cases. Finally, issues like anticoagulation, proximity of local structures, and the different heat capacity of the different RCC subtypes are not of concern in SABR. And the last thing I want to mention is something called the heat sink phenomenon, which I've seen once in exam questions. It's an issue with radiofrequency ablation, whereby local blood vessels and airways near the lesion can conduct heat away from the treatment area, so treatments are less effective. The question that I saw asked about techniques to mitigate the heat sink phenomenon, and the answer they're often looking for is pre-embolization of vessels. That's an option to help mitigate the heat sink effect. I did warn you that RCC would take the longest because there is so much to talk about. The others are not going to take anywhere near as long, and the first is AML, Angio Myo Lipoma. Thankfully, the name says it all. It tells you what it's made of. Angio, thick-walled blood vessels, myo, smooth muscle components, and lipoma, macroscopic fat. Because you know what it's made of, you know what the imaging is going to look like. The two things to mention here is that they tend to be asymptomatic unless they bleed. Bleeding risk is increased above 4 centimeters. And the second thing to mention is 40% of patients with AMLs will have tuberous sclerosis. So if you spot an AML in your exam, you keep scrolling looking for the other features of tuberous sclerosis, which I will mention in a few moments. As I've said, the word Angiomyolipoma tells you exactly what it's made of, so you already know the imaging features. The L stands for lipoma. A renal lesion with macroscopic fat is diagnostic of AML. It's going to follow fat signal as you'd expect on MR. Remember, the fat in an AML is not intracytoplasmic, it's macroscopic, so you're not going to get a signal drop on the chemical shift imaging. The angio means it's full of blood vessels, so any non-fatty bits of the AML are going to be very avidly enhancing. And finally, the myo is smooth muscle components, so you're going to expect these to be low signal on T2MR. That's all very straightforward, and none of that is particularly interesting, but things get more interesting in two instances. We've established that AMLs contain fat because it's in the name, and macroscopic fat in a renal lesion is virtually diagnostic of AML. But the first problem is this, that some renal cell carcinomas can also contain fat. So what's the solution? Well, it all comes down to why an RCC will contain fat. Within an RCC, you can get bone formation or osseous metaplasia. This leads to marrow fat formation as part of the bone making process. So it figures that an RCC containing fat, because it's making bone, is also going to contain calcium. This helps you because an AML will never contain calcium. It's never calcified. You can never say never in radiology, but basically never. So that solves your problem for you. A fat-containing lesion with no calcification is an AML. A fat-containing lesion with calcification might be an RCC, so we'll need biopsy. That's problem one. Problem two is this. I've talked a lot about how fat is a key feature of AML. But what if an AML doesn't contain much fat? Because that can happen too. Well, then we have a problem again. Because remember, all the non-fatty bits of AML will enhance avidly. So the AML, the top picture is an RCC, the bottom picture is an AML. If you have an AML with no fat, then what you're left with is an enhancing solid mass arising from the kidney, which is going to be indistinguishable from an RCC. There are two things that you can do in this instance. The first is MRI. Remember, AML is full of smooth muscle components, which are going to dominate once you've lost the fat. So you'd therefore expect an AML to be low signal on the T2 weighted MR. If you do an MR and the lesion is high signal on T2, then it's probably a clear cell RCC, which we already know is high signal because of its nested alveolar architecture. If the lesion is low signal on MR, it could be an AML, but it could also equally be a papillary RCC, which remember that was low signal on T2. In that case, you need to biopsy. Some books do say that if it's high signal on T2, you can go ahead and treat it as a clear cell RCC. Practically in the real world, they pretty much all get biopsies. Here's a nice example of an AML, and you can see the macroscopic fat within the lesion. Oncocytoma is next. These are benign lesions, but they're annoying because they're indistinguishable from RCC. The other important feature for your exam is that they are a classic feature of Birt Hogg Dube syndrome, something I will cover in a few moments. All the classical imaging features and the demographics for oncocytoma can also pass for RCC, so these are always resected. Often males in their 60s, they're avidly enhancing heterogeneous masses with a central stellate scar. All of these can also be features of renal cell cancer. Who gets renal lymphoma? Lymphoma is next, and this occurs in people with systemic lymphoma elsewhere or people who have recurrence of previously treated lymphoma. Immunocompromised patients are also at risk, but it's extremely rare to have lymphoma as a primary lesion in the kidneys. There are 5 common imaging patterns you ought to be aware of, and I will take you through those 5 now. The first and second common imaging patterns of lymphoma can be seen here on this picture. On the right is the most common pattern in around 60%, and that is multiple renal masses between 1 and 3 centimeters. You can see here, following contrast, the kidneys have enhanced nicely, but you have these homogeneously low attenuation areas within that enhancing kidney. You often also have associated retroperitoneal lymph nodes, but calcification is very uncommon. So your first common imaging pattern of renal lymphoma is multiple homogeneously hypoattenuating masses within a normally enhancing kidney with associated retroperitoneal lymph nodes and no calcification. On the left is the second pattern of lymphoma in a kidney, which is a solitary mass. Solitary mass occurs in around 10%. Again, it looks the same, so hypovascular, homogeneously hypoattenuating, non-enhancing within an otherwise normally enhancing kidney. This here is pattern 3. Pattern 3 is contiguous extension of lymphoma into the kidney from retroperitoneal disease. This is quite common, and the main findings to help you spot this as lymphoma are as follows. First of all, you have this big, bulky retroperitoneal mass that will envelope the renal vasculature and then invade the renal hilum, which you can see on this picture. A characteristic finding to show you that it's lymphoma is that the renal arteries, although surrounded by the lymphomatous mass, will often remain patent. So patent arteries and vessels, even though they're encased by tumour, is characteristic of lymphoma. Thirdly, you can often see hydronephrosis. Remember, the mass invades the renal hilum and compresses the collecting system. So hydronephrosis is common. And finally, renal displacement that you can see here is also very common. So these are the main features of pattern 3, which is contiguous extension from retroperitoneal disease. Pattern 4 is perirenal disease. Now, usually when lymphoma gets into the perirenal space, it's either because it's extended outwards from renal lymphoma, or it's extended inwards from retroperitoneal lymphoma. Rarely you can have this pattern, pattern 4, which is isolated perirenal disease. This is lymphoma that surrounds the kidney within the perirenal space but doesn't cause any compression of the kidney. It's a rare pattern, but I've mentioned it because it's virtually pathognomic of lymphoma and will therefore be an excellent exam question. Finally, pattern 5 is infiltrative disease. So with infiltration, the way lymphoma spreads into the kidneys is that you have bilateral seeding of tumour throughout the renal interstitium within the cortex. Now the tumour begins within the interstitium and it grows through that interstitium using the nephrons and the collecting ducts and blood vessels as a framework. This means that the parenchymal structures are being used as framework, and the structures themselves tend to remain relatively quite well preserved, which is why you don't tend to get renal failure with renal lymphoma. What you'll then see on the kidney, because it's all being spread through the interstitium, what you'll see on imaging is bilaterally enlarged kidneys with a nicely preserved renal contour. Infiltrative lymphoma is almost always going to be bilateral and patchy, poorly defined. In fact, it's often diagnosed only on post-treatment scans in patients with lymphoma when someone spots that the kidneys are suddenly smaller compared with the initial pre-treatment scan, and they realise that's because the kidneys were initially full of lymphoma. So that's the solid mass lesions done. There are now 3 pseudo masses or pseudo lesions that I need to mention because they are favourite exam questions. The first is a hypertrophied columns of Burton. So what are these? The kidneys are made from multiple lobules that are fused together. Each lobule, you can see here, has a core of medullary tissue surrounded by cortex. So as the lobules all come together, between each lobule, you have 2 layers of cortex fused together, separating the pyramids. Sometimes there is some unusual enlargement of these columns or these cortexes fused together, cortices even, and these columns of Burton, when they enlarge, can look like a mass. The key to identifying this is that on any imaging, it looks like renal cortex, it behaves and enhances the same way as renal cortex does, it's continuous with the cortex, and the renal outline will be nicely preserved. You don't tend to get a nicely preserved renal outline with renal cell carcinoma. So that is hypertrophied columns of Burton. They are simply extensions of cortex between the pyramids that can look like a mass on ultrasound, but will behave and look like cortex in every other way. Now, if these renal lobules do not fuse together properly, then you get the second pseudo-lesion, which is persistent fetal lobulations. This is a normal variant where the lobules, as I've said, haven't fused together and the kidney surface will look bumpy because of these indentations between the pyramids. It can therefore look like exophytic lesions, but the key here is that you're going to see columns of Burton on each side of these exophytic areas. The final pseudo-lesion is a dromedary hump or a splenic hump. This is a focal bulge on the lateral edge of the left kidney caused by the splenic impression. That's the spleen there. And it can look like an exophytic mass, but you can tell it's not because the calyces that lie deep to this hump, these are going to extend further out than the other calyces. Also, it's going to look the same as the rest of the renal cortex in every other way. So that's the 3 pseudo-lesions. They are hypertrophied columns of Burton, persistent fetal lobulations, and dromedary or splenic hump.
Well, my friends said you figured out. Yeah, they saw what's inside of you. They try hiding another you, but your evil is coming through. These are sitting on the wall. Well, they watch every move I make. Bright light living in the shade. You cold harmless with spirit shade. I had to go through hell to prove I'm not insane. And to me, the devil just should know his name. And that's when my love was burning. Yeah, it's still burning. And I keep going to the river to pray, 'cause I need something that can wash out the pain. And I'm sleeping all these demons away, but your ghost, the ghost of you, it keeps me awake.
We are almost done, but if you do require a longer break, hit pause, go make yourself a coffee, go and lie down, and then come back and we'll do cystic renal lesions. Now, a renal cyst can either be a simple cyst or it can be something else, and we're going to quickly run through these. Simple cysts, first of all. Cysts are classified according to Mr. Bosniak from 1 to 4. Mr. Bosniak only actually died in 2016, I learned that today. So a Bosniak 1 is a simple cyst. We don't call it a Bosniak 1, we just call it a simple cyst. It has HU values between 0 and 20. A hairline thin wall and no septations, no calcification. That's what they look like. They're benign. You don't need to follow those up. A Bosniak 2 can have a few hairline thin septations. There can be some thin, short length calcifications of the septae or the wall, but they will have no measurable enhancement. The other type of cyst in the Bosniak 2 category is a hyperdense cyst that is 3 centimeters or less. Now, a hyperdense cyst is a regular renal cyst that at some point has had some hemorrhage or infection or something happen to it, and now it's become hyperdense. So it now sits with a higher density than regular cysts. This is a hyperdense cyst on a plain scan. Obviously, to define a cyst as hyperdense, you need to have the pre-contrast imaging. The pre-contrast will show it to be of high density, and then the post-contrast will confirm a lack of enhancement. They like to put this in exam questions. If all they've given you in the question is a post-contrast scan, you cannot call something a hyperdense cyst. That's a silly thing to do, and you will lose a mark for no reason. So Bosniak 1 and Bosniak 2 are benign, do not require any follow-up. A Bosniak 2F does require follow-up. The F stands for follow-up. These have a very small chance of being malignant, and the way to differentiate these from a Bosniak 2 is that they will have more septations than a Bosniak 2. The septations are often slightly thicker rather than hairline thin, and they can have smooth wall thickening and nodular calcifications. Again, there is no measurable enhancement in a Bosniak 2F cyst. When talking about hyperdense cysts, any hyperdense cyst above 3 centimeters is also a 2F. There are no agreed rules for the follow-up interval. At my current trust, we tend to say a 6-month interval follow-up imaging is adequate. So a Bosniak 1, remember, was a simple cyst, no septae and hairline thin wall. A Bosniak 2 can have a few hairline thin septae with some thin calcifications allowed. A 2F will have thicker calcifications and more of them. It can have some nodular calcification and smooth thickening of the wall. As far as a hyperdense cysts are concerned, if it's 3 centimeters or less, it's a Bosniak 2. If it's more than 3, it's a 2F. So that's Bosniak 1, 2 and 2F. And none of these have any measurable enhancement. Once you're able to measure enhancement within a wall or within septations, you then enter Bosniak 3 territory. Bosniak 3 then has measurable enhancement. It can have thickened and irregular walls or septae. Finally, a Bosniak 4 has a soft tissue components with measurable enhancement. Classification of renal cysts is a guaranteed exam question. You will definitely get one question asking you to classify a renal cyst within the Bosniak category. If you don't learn it, you're an idiot. As a general rule of thumb, Bosniak 1 and 2 are benign. They have no chance of malignancy and they don't need follow-up. Bosniak 2F is also probably benign. The chance of malignancy is tiny, 5%, but they do require follow-up because of that 5%. A Bosniak 3 is classified as indeterminate because the risk of malignancy is 50-50. And a Bosniak 4 is almost certainly malignant. When I say malignant, I mean it's probably a cystic renal cell carcinoma. There are 2 other cystic lesions to cover. We're almost done. The first one is MEST, mixed epithelial stromal tumor. This is a recently described entity. There are only around 100 cases in the literature so far, and as the name suggests, they're mixed solid and cystic masses with both stromal and epithelial components. The key here, what you need to know, is that you can't confidently say it's not a cystic RCC based on imaging alone. All of its features can pass off as features of cystic renal cell carcinoma. So what are those features? It's usually a multiloculated mass herniating into the renal pelvis with lots of thick enhancing septae, mural nodules and calcifications, and sometimes also intralesional hemorrhage. There can be some clues from the history. We know that it tends to affect perimenopausal women, and we also know that it's associated with estrogen supplementation and use of the contraceptive pill. But realistically, it looks way too much like a renal cell carcinoma to start hedging your bets on that. So these are almost always resected. Final lesion, we have multilocular cystic nephroma. This is classically a disease of young boys and middle-aged women. For some reason, it's been nicknamed the Michael Jackson tumor. For legal reasons, I would like to categorically state that I have no idea why it's called the Michael Jackson tumor. I'm simply mentioning it in case it serves as a memory aid for some of you. It's actually a spectrum of lesions. Some people think that both cystic nephroma and MEST that we just talked about are on the same spectrum of disease. Again, you have this multiloculated cystic mass with enhancing septae. Again, they tend to herniate into the renal pelvis or the proximal ureter. A clue to cystic nephroma, in addition to the demographics, is that the septae are fibrous, and so the septations will be low signal on T1 and T2 imaging. But again, like with MEST, we can't be sure, so we tend to surgically resect these also. That's it. We're done with solid and cystic masses. We're going to end with the 3 syndromes that feature renal masses and are favourites for examiners. And we'll start with von Hippel Lindau. We've already met VHL when we talked about clear cell RCC, which is caused by inactivation of the VHL tumour suppressor gene on chromosome 3. So VHL is a disease of multiple tumours because you are inactivating a tumour suppressor gene. These tumours are both benign and malignant. Trying to memorize them all is a colossal waste of your time, so I've summarized the key lesions for you in a handy acronym. The H stands for hemangioblastoma, and the other brain lesion, choroid plexus papilloma. The A is adrenal pheochromocytoma. The R is for renal. We know they have RCCs. They also get renal cysts and AMLs. And finally, the P is pancreatic lesions, adenocarcinoma, cysts, and serous cystadenoma. The next syndrome is tuberous sclerosis. Again, another one that people spend ages learning, but you don't need to, because again, I've summarized it into a more palatable way for you. There is, of course, the classic triad of seizures, mental retardation, and adenoma sebation. Learning that is dumb. It's not going to help you in an exam because they're not going to ask you this. What they're going to ask you are the features of the disease that I have divided up for you into brain, abdomen, and thorax. And I've given you 2 features per area. We'll start with the brain, and the 2 key features of tuberous sclerosis within the brain are tubers and subependymal hamartomas. Let's start with the tubers first of all on your right, on the radiological right, and these are cortical or subcortical hamartomas, which are triangular lesions with their apex pointing towards the ventricles. You can see them there, these high signal lesions. 95 to 100% of patients with tuberous sclerosis will have tubers, usually in the frontal lobes. They are hamartomas, so they'll be low signal on T1 and high signal on T2. They do not enhance nor do they calcify. So the subcortical or the cortical tubers will most likely not enhance and not calcify. The other lesion on your left, these are subependymal hamartomas. They're again hamartomas, but in a subependymal distribution, and these occur in 80% of people with tuberous sclerosis. The difference here is that you can see they're calcified, so most of them, 88%, will calcify and they can enhance. So I'll say that again, the 2 lesions in the brain on the right are the subcortical and cortical tubers. These are hamartomas which look like triangular lesions with their apices pointing towards the ventricles. Almost all patients with tuberous sclerosis will have these tubers in the frontal lobes. There'll be low signal on T1 and high signal on T2. They do not enhance, they do not calcify. The subependymal hamartomas that you can see on the left, they do enhance and they do tend to calcify. An important feature here of the subependymal hamartomas is they can grow into something called SAGA, subependymal giant cell astrocytoma, which again, of course, is associated with tuberous sclerosis. So how can you tell the difference between a SAGA and a regular subependymal hamartoma? Well, the answer is it's very difficult. We do it by serial measurements. So a subependymal hamartoma, I've already said, can be calcified and can enhance. So that's not going to help you differentiate it from a SAGA. When a subependymal hamartoma begins to grow and you follow it on serial measurements getting bigger and bigger, that's when you worry about it developing into a SAGA. So that was tuberous sclerosis in the brain. Tuberous sclerosis in the abdomen is what we've already mentioned: bilateral renal cysts, renal AMLs, and renal cell carcinomas. Finally, tuberous sclerosis within the thorax. Again, there are 2 things to remember. The first is within the heart. Children with tuberous sclerosis will have something called a rhabdomyoma. This is a hematomatous lesion, usually within the ventricular septum. Most of these are diagnosed before the age of 1. They don't need treatment. The vast majority, 70%, will regress of their own accord. Rhabdomyomas are very, very strongly associated with tuberous sclerosis. Half of these patients will go on to be diagnosed with tuberous sclerosis. That's the first thoracic TS lesion. The second one is a disease similar to lymphangioliomyomatosis. It's essentially multiple cystic lesions and a chylothorax within the thorax. That was tuberous sclerosis, which we divided into brain, thorax and abdomen. And we're going to end with Birt, Hogg, Dube, and my way of remembering the features of this syndrome. As far as I'm concerned, BIRT stands for bilateral renal tumours, classically chromophobe and oncocytoma. Both of these have the same progenitor cell. They originate from the same cell lineage. So Birt is bilateral renal tumours. Hogg, this is a horrible thing to say, but they have multiple skin lesions, often angiofibromas, and I remember that as looking horrible like a pig, but that's not to offend anyone, it's just to help you remember things. And Dube looks a bit like tube, and these patients often have tubes in their chest from the pneumothoraces they get as a result of having multiple pulmonary cysts. So Birt, Hogg, Dube is a disease of bilateral renal tumours, multiple skin lesions and pulmonary cysts and resulting pneumothoraces. That's it. That's all the lesions and all three syndromes. So we're going to end with a very quick name that tumour. If you want to take a break, but you may as well carry on. There's only another minute or so to go. We'll start with this one. Just shout out the name of the tumour and we'll move on. I'll give you 1 second. This is a lesion arising from the kidney with macroscopic fat. There is no calcification. This is an Angio Myo Lipoma. Next, name that tumour. There are multiple homogeneously low attenuation masses within the kidneys bilaterally. The kidneys are otherwise normally enhancing. There is also retroperitoneal masses. This is renal lymphoma. Next, name that syndrome. Okay, here's the answer. We have a hemangioblastoma, cystic lesion with an enhancing nodule within the cerebellum is a hemangioblastoma. An adrenal pheochromocytoma. We have renal masses and renal cysts and multiple pancreatic masses. HARP was the acronym I gave you for von Hippel Lindau. This is VHL. Let's move on. I couldn't resist. It's histology. We're not pathologists, but what do you think this is? There are multiple projections, nipple-like projections with a fibrovascular core. I'll give you some clues. This is going to be a poorly enhancing lesion and it's going to be low signal on T2 weighted MR imaging because of this papillary pattern. This is a papillary RCC. Name that syndrome. We have angiofibromas here. We have multiple bilateral renal masses, one of which looks a bit like an oncocytoma, but we can't say for sure, remember, because we can't tell those on imaging. And we also have pneumothoraces with multiple pulmonary cysts. This is Birt, Hogg, Dube. Phew, that's it. That was renal mass lesions, and it should be everything you need to know for your 2A and 2B exams. Hope that was fun and a good use of your evening unwinding time. If you haven't already, check out the previous video on liver tumours and also the podcast on all good podcast providers. All updates are posted on Twitter and handouts for all podcast episodes are added to the Google Drive folder. Keep revising and we'll see you next time for prostate imaging.